Ladies and gentlemen, please welcome BCRF's Scientific Director, Medical Director of the Evelyn Lauder Breast Center, and Senior Vice President, Office of the President at Memorial Sloan Kettering Cancer Center, Dr. Larry Norton.
Good morning. I also welcome to the stage our colleagues, Judy Carver, who heads our Scientific Advisory Board, and as of last night is the co-scientific director of the BCRF. They can show your names up there. Yeah, look at that. Now I know who you are. Hedy Resac is from Memorial Sloan Kettering. I'm going to let them all talk about themselves as we go forward. And is the Chief of Radiology at Memorial Sloan Kettering and is the winner of the Joe Rose Award this year. Joe Sparano, I'll let them just at Ben Ho Park, and of course Judy. So, hey, welcome. Come on, be lively. This is something we look forward to every year as one of our most exciting events in BCRF all year, because this is our opportunity to share our research, our ideas, our findings with you. There are usually lots and lots of questions. We can't obviously answer specific questions about specific cases, but we can talk in generality about major issues that are relevant to specific cases when they arise. And just to make it most efficient, what we're planning to do is to hand out cards, and you'll have cards, and you can write your questions, and then a little later, once we get going with the session, we'll get to your questions and we'll answer your questions. We have all the investigators spread out along the sides of the room. We've got experts in literally everything that's related to breast cancer that's here, as well as on the stage and on the sides. So any question you can come up with, no matter how strange and bizarre and difficult, we can handle it. Somebody can handle it. And if we can't handle it, I'll just make up an answer. So one way or the other, or two. So to get us started, let's just go through our panelists, and we'll all have a chance to talk about who they are and where they're from and what they do, and have a conversation among ourselves for a while, asking each other questions before we open it up to the question cards. Hedy, start us off. Who are you?
Thank you, Larry. I am Hedy Resac. I'm a radiologist, a diagnostic radiologist. I spend I spent wonderful years at UCSF, but for the last 20 years, I'm chair of radiology at Memorial Sloan Kettering. My expertise as it comes to breast cancer is really trying to push the envelope in understanding metastatic disease. And it really, as everybody is now trying to practice, and we are really, our aim is to practice precision oncology, imaging in metastatic disease plays a tremendous role because you need to know when, how, and how much to treat. So that is my area. Another big passion of mine is global education. We are one world, and if we can help women in low middle-income countries, it's a big help, and I think it's almost our duty and ethical part, and that's why I very much embrace global education.
Joe, who are you?
So my name is Joe Sparano. I'm a medical oncologist at Montefiore Medical Center, Albert Einstein College of Medicine. I've spent my entire career there, 32 years, as a clinician with a sort of broad interest for the first 15 or 20 years of my career, and focused on breast cancer and specifically clinical trials in breast cancer for the last 15 years. And my interest has been trying to apply technology, diagnostic tests to help understand who needs to be treated and when they need to be treated. And the BCRF has supported work, I think two of the most important pieces of work that I've been involved with in the last year at the front end in the diagnosis of early stage disease to use a gene expression test to identify who really benefits from chemotherapy so that we can spare those who don't need it. And at the back end, for those women who are out 5 or more years after chemotherapy or standard therapy, the diagnosis of their disease, to identify those women who are risk for late recurrence of their disease, and not only to identify who's at risk, but how we can mitigate that risk.
Ben?
Thanks, Larry. Is this on?
Yeah.
Okay. Sorry about that. My name's Ben Park. I'm a physician scientist, breast medical oncologist, and for 20 years I was at Johns Hopkins, but as of September 1st, I'm now at Vanderbilt University Medical Center, where I'm now the co-leader of the breast cancer program as well as director for precision oncology. My research interest really has been to use genetic kind of anomalies that we find in breast cancer for both diagnostics and therapeutics. In particular, a lot of the work that we've done over the past decade, which has been supported by BCRF, is really looking at or developing blood tests so that we can really figure out who needs therapy and when and at the right time, and have some sort of clue as to whether patients in early stage disease are actually cured of their disease or whether they would really benefit from additional therapies. Thank you.
Judy?
I'm Judy Carver. I'm at the Dana-Farber Cancer Institute in Boston. There, I'm the chief of the Division of Cancer Genetics and Prevention, and I'm a breast oncologist working in the breast program as well. My work has been in identifying individuals at risk for cancer based on genetics, and with many colleagues in the BCRF, we've tried to look at novel ways to do that, to make genetic testing more accessible, to cover more genes and more people, to try to help sort out individuals who need extra care, either through monitoring or through management, possibly surgery, and also to develop treatments that were of particular benefit to women at increased risk based on genetic factors.
Okay, are we done? No? We're covering the whole spectrum here, really, with this extraordinary panel that we have of some of the most cutting-edge stuff that's happening, really, at the present time. When you think of radiology, you know, for breast problems, you think of screening. You think of the primary disease in the breast. You know, women go for mammograms, you know, and sometimes they go for MRIs, and we do sonograms and other imaging kinds of techniques. I think most people, when they're thinking about breast radiology, they're not thinking about metastatic disease. It's a relatively new thought that actually sophisticated imaging of metastatic disease could lead advances. All right. But this is something that you're championing and you're leading, you know, although obviously in your department, you know, you have many people that do breast screening as well. I mean, what do you think the prospects are that we're going to routinely be using screening tools to look for metastatic deposits and addressing them in a meaningful way?
So first of all, as a chair, my role is really to encourage and to support the faculty and the department to do so. Everything that I'm saying or I present, it's really the work of our team, correct? And then another thing is, I think that our work very much, the reason we have results is because we work as a team with our medical oncology, and I have to tell you that I have never seen anybody, any physician more visionary than Larry Norton.
Okay, that's the end of that comment.
Yes. It's true.
No, stop it. It's just, first of all, it's totally not true.
And he is pushing us. It's never enough. When we had MRI for metastatic disease, he said, well, that's fine. Can't you do better? Then we have estrogen imaging to look, because breast cancer is a hormonal disease. So we are doing estrogen imaging to really identify metastatic. Cancer continuously differentiate. So you may have certain receptors, and then 6 months later you don't.
Right, you're zeroing in on something I think is, and this is something I was impressed with. We had a scientific seminar yesterday where, just among the grantees in a scientific seminar, and something extremely impressive, and I think you're touching on it, which in general, I think the public doesn't really know. They think of cancer as, you know, there's a cancer cell and it grows in the breast and then it can spread to other parts of the body, and it's a homogeneous process. You know, your cancer cell spreads, all right? But you're sort of addressing two issues, I think, simultaneously. And Ben, I want to get you into this as well, and you know, in this discussion, which is cancer is not cancer is not cancer. I think that should be the theme, really, of the day. It relates to prognostication, really, as well. And you're saying that you could start off with a hormone-responsive cancer, there's estrogen receptor, and it could change.
Absolutely. And we know that through imaging, it's a molecular imaging, where we can identify tumor targets on the tumor, hormonal targets. So you can do estrogen imaging, and you're going to see estrogen receptor. You can do androgen imaging, because they are much more qualified to tell you. But as we see, especially late onset of metastatic disease, those women very often the metastatic disease behaves very similar to prostate cancer. It stays in the bone. And we know it actually has androgen receptors. And if we can show that, then our medical...
Androgens are male hormones, right?
Male hormones. Then our medical oncology friend can then think differently and design different therapies. That's where molecular imaging is so important.
Right. Does this apply... Well, let me ask this question, Ben. What's a driver mutation?
So I think when we call things driver mutations, what we're really suggesting is that
Start off with, what's a mutation?
Right, I was just going to get to that. What we're really driving at, no pun intended, is the fact that all cancer really is a disease of our DNA. DNA is kind of the blueprint of what makes us us, and so every cell, with some exceptions, has 2 copies of DNA, one from mom and one from dad. And we have safeguards in place that every time a normal cell divides into 2, that the fidelity is 100%. Meaning that those 2 daughter cells, if you will, are identical twins. In cancer, that doesn't happen. And so there are a series of mistakes in the DNA, and that's what we call a mutation. And those mutations are often what drive growth, invasion, metastasis, et cetera. That's what we call a driver mutation. The reason we use that moniker is because we do also know that there are mistakes that just happen that have no functional consequence, and that's what we would call a passenger mutation. Most of us in this business are really kind of looking for the driver mutations, because those are the things that we hope to target, but those also give us the ability to do diagnostic tests, things like looking in the blood for DNA mistakes that represent cancer cells that may still be in the body.
Right. Well, because one of the things that impressed me when I saw yesterday is that if you're looking at abnormal molecules related, to cancer on some of these images, that it's not homogeneous. Not all the cancer cells have them, and not all the spots have them, and even in one tumor, you can have variability. Is that the case?
And absolutely. Within a tumor, what we call intratumoral, that's within the tumor, there is a tremendous heterogeneity. Some part of the tumor can overexpress HER2, and some do not. So by imaging and by in vivo seeing that matrix or composition of the tumor, and that's work in progress, will allow medical oncology perhaps to prescribe 2 drugs and not just 1, chemotherapy, and that's future of precision medicine. And also, if one drug works with your friend, it may really not work with you. And to be able for our medical oncologists to give you a precise treatment, they need diagnostics, as John said, and molecular imaging. It's only one element of diagnostics. It's not the entire picture, but it's extremely important one.
Does this relate to primary disease as well, Joe? I mean, the fact is that, again, the lay public tends to think of breast cancer as breast cancer. And now we're hearing about the fact that different mutations may be involved in breast cancer. Breast cancers may have different patterns of genes. How does this relate to the treatment of primary disease? Talk a little bit more about the TAILORx.
Yeah, well, certainly one of our challenges is that the tumors are heterogeneous. They're not all alike. Not all the tumor cells are alike. And we know that because if you had an estrogen receptor positive tumor and you use anti-estrogen therapy and that tumor should be dependent upon estrogen for its growth, no one should have a recurrence. Same thing for a HER2 positive tumor. And by using some of these tests, and I think we're most advanced now for the ER positive, HER2 negative tumors, we can use.
All right, we got to go to this. ER positive, what does that mean?
Estrogen receptor positive tumors,
Okay.
The most common subtype of breast cancer, about 70% of all breast cancers express the estrogen receptor and therefore are potentially dependent upon estrogen for their growth. So the tests that are available now that can be done on the tumor that evaluate the gene expression have demonstrated the greatest usefulness in that subset of women, which is the largest subgroup, to identify those tumors that are more likely to be estrogen dependent and do well with anti-estrogen therapy, may do well alone without any therapy, or derive a large benefit from chemotherapy.
I have to just editorialize here because, I mean, this sort of really blew me away, you know, this data, which it's been evolving with this gene test that actually, you know, you can look at the activity of certain genes in early breast cancer, the most common type of breast cancer, which is not involving the nodes and also having estrogen receptors, you know, in the tumor. And that some of those patients have a really extraordinarily good prognosis with anti-hormone therapy without chemotherapy. Others really need chemotherapy, which can put them in a good prognosis situation. And when I first saw this, and this is just, again, just editorializing, is that I remember the very early days when I started doing cancer medicine. It was actually before doing cancer medicine, even when I was just training in medicine, is, you know, a person would have a breast cancer. Most of the breast cancer we were seeing then were not from screening, were not mammographically diagnosed. The patients felt lumps, or a doctor felt a lump, and they were usually, you have to be pretty big to feel the lump, so they were more advanced cancers than, for the most part, we're seeing now in a screened population. And you know, it was breast cancer. You know, it immediately had implications about mortality as well as difficult therapy, including surgical therapies that in those days were mutilating because they involved taking the muscle off the chest wall and doing extremely aggressive operations, really for everybody. And the whole notion that you can have cancer and you can do molecular tests and say, it's cancer, but it's really, your odds are great that you're going to be totally fine, and you're not going to need very much in the way of systemic therapy. You could take this pill, you know, and very few side effects. If you have side effects, we can change the pills, we can overcome. It's like astonishing. I mean, it's astonishing to you to say you have cancer and you really don't have very much to worry about. I mean, that's an amazing thing to somebody who grew up in an era when the big C automatically meant, you know, mutilation and high likelihood of death. And I think this has just been an extraordinary, it really hit me between the eyes when this really occurred. And it's really because of advances that have happened all here. You know, ability to diagnose things earlier, ability to analyze them, understanding the relationship between molecular abnormalities and the behavior of the cancers, and also, you know, identifying people at high risk for breast cancer so that you can have interventions even before the breast cancer develops, which is the ultimate of where we're going with our thinking, is ultimately toward prevention. And I think all of these topics really relate to that. What's happening in the area of prevention, Judy? You got a mic.
Yes, sorry. We had a meeting just on Tuesday, brought together 30 experts to think about prevention, because you'd assume by now, with all of this molecular transformation of our understanding of breast cancer, that we'd have figured out who's at risk and how to help prevent breast cancer, and we certainly have learned a lot. We're better at identifying some people at the very highest risk groups, people who have mutations in BRCA1 and 2 and other genes, but we're not very good overall at telling any one woman exactly or even approximately what her risk is, except using very broad general population figures. And we have found drugs that will help significantly prevent breast cancer. You know, tamoxifen actually works. Nobody wants to take it, but the most amazing thing about tamoxifen is that if you actually take it for 5 years, at 20 years, its effects are still there. You're still have a lower risk of getting breast cancer. And I don't still know of any drug you can take that works once you stop. Even statins, which I know are miracle drugs and will keep us alive forever, you have to take them for them to work. Now, the problem is that's true for treatment, too. You do actually have to take them. But even for prevention, and even with figures like that, it's hard for people to accept this. So the focus now is on bringing precision to prevention. So how much better can we help identify risk, not just in the very highest groups, but across the population? So people are working on using SNPs, which are little pieces of DNA, which individually can tell you a tiny amount about risk, but taken as a group can help stratify a group of women into much more precise risk estimates. We're looking at, and people are looking at things like mammographic density, which you now get a letter from your radiologist about after your mammogram, you have or you don't have, and we haven't quite figured out how to manage all this yet, but we're getting there. People are thinking about immune strategies, so we don't really want to take medication, let's be facing this. Maybe we could have a shot to prevent breast cancer. We haven't clearly wanted to have diet, exercise, and avoiding all alcohol give us breast cancer. I mean, maybe it's worth it if you can't, you have to do a little, but no, I don't mean that. But I do think that this issue of, how we take care of ourselves is important, and helping women to do that in easier ways is critical. So we've made progress, but we still have a long way to go.
But we have all the pieces. I mean, what was really impressive to me about sitting in on the last hour of that meeting yesterday is it isn't like, gee, what should we do? It's a question of all these things that we can do, which one should we do? Because there's enormous, there's so many ideas. It's a matter of selecting rather than hunting.
Right. It can't just be one. That's clear. I mean, here, as you hear, there's not one breast cancer, neither will there be one way to prevent breast cancer, and so we're going to have to figure this out in a more sophisticated way.
I think we should get to immunotherapy in a second, and we actually are honored to have two of the real leaders of raise your hand, those of you who read the recent news reports about an immunotherapy for breast cancer, just so I know that we're going to have to. It's a minority of you, so we're going to have to sort of talk about that. But we had some really extremely interesting and important results in the immunotherapy of metastatic breast cancer that I think we should also talk about. And two of the leaders of that are actually among us, among the grantees of BCRF, and I think we should get to that in a second. But I want to get back to this notion of cancer is not cancer is not cancer. All right. And how it relates to earlier diagnosis, in many things you talk about prevention as preventing the first occurrence, but the fact is that for the most part, when we're talking about prevention, we're talking about catching something early enough that there's a signal there's going to be a problem, but the problem hasn't arisen yet, and we can sort of intervene. We don't treat for high blood pressure until somebody has high blood pressure, for example. And you say that treating high blood pressure is a preventative strategy for heart disease and stroke, and that's true, but it really isn't. It's really early intervention at the first marker, the first indication, biological indication that something's going wrong with your cardiovascular system, which is high blood pressure or high cholesterol or something of that nature. So very, very early diagnosis and intervention so a problem doesn't arise is really tantamount to prevention. And for the most part, when we talk about prevention, obviously there's, right now my people who are interested in diet, I see Walt over there are cringing, and saying, Larry, you're wrong. But very often when we talk about prevention, at least in many cases, that's really what we're talking about. So what are the prospects of actually things like blood tests, all right? You're talking a lot about blood markers and mutations, Ben. What are you talking about?
So one of the things that was discovered many years ago was that all cells shed or secrete DNA into the circulation, and these are short little fragments of DNA. We still don't know if they have any function. Many of my colleagues have heard me call it cellular poop, because basically they just get spit out into the circulation and gets filtered away in the kidneys, and it's a waste product. But we haven't really been able to do much about that knowledge until recently, when we had new technologies, things called next-gen sequencing and also digital PCR. These are just platforms that now allow us to analyze every single molecule of DNA individually, but we do it massively in parallel, is the phrase, so that we can actually do it fast. And that's what has really allowed us in the liquid biopsy field, as we call it, to pluck out these free-floating DNA molecules. Remember what I was saying earlier, that cancer is a disease of DNA gone bad. And it's not just one driver mutation, as we were saying, it's multiple driver mutations. As I was saying earlier, when cells divide, normally they're the identical SIBs, but in cancer that doesn't happen. And that's what makes it so difficult to treat, because of this heterogeneity that we were talking about. When you think about when you take a biopsy or you're looking for a lesion that you don't know is cancer or not, if we had the capacity to take a tube of blood from a patient or a prospective patient and then look through all those DNA molecules and look for driver mutations, that would be the first step to say, aha, we can perhaps diagnose someone a little bit earlier. Maybe say if you had a relatively low-risk looking mammogram, maybe if you had a positive blood test, you might biopsy that patient where otherwise you would not. And the other aspect that we're trying to do is also make sure that every step of the way, this goes to what Dr. Sparano has been doing, is to not overtreat. Because we already know in breast oncology that many of the patients that we treat really don't have microscopic disease based upon stats. And microscopic disease is really what we're talking about, what we're trying to eradicate when we give chemotherapy and hormone therapy. because that's the stuff that can come back as true metastatic disease in the future.
These are cells that are spread from the breast to other parts of the body that could then grow and cause trouble in those organs, right?
Exactly. And so if we had a way to detect microscopic disease, either through imaging or through genomic tests of the tumor itself, like Dr. Sparano's has done, that would give us a lot of information that we could start doing this precision oncology where we can treat patients individually and know whether or not they need the second step therapy of chemo or radiation, et cetera. And so parlaying that to earlier diagnostics and prevention, one could see a situation where if we really incorporated all these different modalities of radiology, molecular imaging, genomic tests, BRCA testing for heritable types of SNPs and other types of genes, we may be able to, as a field, in fact, I would be as bold to say we will be able to, as a field, come together and really develop precision screening guidelines for every individual. And I think that was what came out of this meeting a couple of days ago, which is pretty exciting.
And you know, the other thing to note, those of you who are BCRF supporters, which is everybody in the room, is that these kinds of advances can't happen by people working on their own particular thing. You know, experts in imaging or medical oncology or molecular oncology or genetic susceptibility. It's going to occur from a community of people that actually can get together and interact and share things and develop. I mean, there's no trials that I know of that are just really focused on sort of a narrow area. They all involve lots of areas, and that's the importance, basically, of the BCRF concept of bringing together a very diverse group of people with lots of different interests, and we have them here, and we have the opportunities for them to answer questions too when we get to the question answering part of this. You were commenting to me a second ago, and I want to get everybody's response to this, that you think that there's some people where they have breast cancer and we're not going to have to treat them?
I know this is very brave, since especially I am not a primary cancer breast imager. I actually spent most of my career on primary prostate cancer. And learning from the field of prostate cancer and listening to all of experts, I will actually predict that 5 years from now, you will not treat every breast cancer. That we already having the very similar challenge, and that is which cancer we can, what we call surveillance, just follow up, and which one we need to treat, and which one we need to be extremely aggressive in treatment. And that is really marker of tumor aggressiveness at the time of diagnosis. And we think that imaging, not mammography, it's called a hyperpolarized MRI, in the future may play
Everybody
a role.
repeat that term, please. Hyperpolarized MRI.
And has no contrast. So that's why, but it may give us another marker to everything that they do, another marker of tumor aggressiveness. And that's really what we want to do. We want to be very precise and helpful and say, please don't worry, come and see me in a year or 2 years, or no, I have to treat you tomorrow and very aggressively.
Joe, what do you think of that?
I agree entirely. I mean, I think there's a revolution going on in the world of prostate cancer. And it's now really the norm for men with low-grade localized prostate cancer to be observed. And the vast majority of those men could actually be spared aggressive therapies that can produce pretty debilitating symptoms. We're not there in breast cancer yet. Part of the reason that I think we're not there is that the surgery and local therapies needed to treat a localized prostate cancer have more potential for causing debilitating side effects than removing a primary breast cancer. And there is an attractiveness to just, if you have a problem, to deal with it and remove it. In the prostate area, that comes with a much bigger price. But I think we may be there. We're now starting to dabble in this area, right? There are 3 different studies throughout the world looking at an observation type of approach, a watchful waiting approach for women who have ductal carcinoma in situ, sort of a precancerous breast cancer. And we may be there in a few years with invasive breast cancer.
Can I, maybe because it's so easy, like you said, maybe not as easy, but fine. but you don't have to then follow with radiation and chemo. And I think that will be the first step in changing the paradigm of treatment. The only reason I'm telling you that is prostate cancer. We used to be so aggressive. It was, my God, when I think back, it was barbaric. And now I think we are we do better job.
Judy, you're looking at me with a quizzical eye.
Pardon me?
What's going on behind those quizzical eyes?
Well, I think to a large extent, this is what breast cancer has always been about. This is really what cancer treatment is about. That there's the tumor in front of you and the patient in front of you, and your job is to figure out what is likely to happen. How do I best intervene? What's the transformation of this is in more than one direction. So we have now already better tools. What Dr. Sparano was talking about, a way to try to divide among the most common types of breast cancer. When do we really need to give chemotherapy, and when don't we? Instead of giving everybody everything, saying, okay, breast cancer, chemotherapy, hormone therapy, we already know we don't need to do that. There are times we can back off, and these are ways of helping make sure that no matter where you live in the country, no matter how good your pathologists are or your radiologists, there's a way to try to have a test that can help you distinguish and make that really a much more reliable way to make a judgment. And with that have had to be, of course, very large trials to help sort this out in a way that we can use, and then mere medical oncologists learn how to do it. The surgeons have done this as well. They used to do, my mother had a radical mastectomy, totally disfiguring. And then we went to less surgery, and then even to less lymph node surgery. Very important, so nobody has to have lymphedema in the way that people used to. So we did manage the side effects, but not just that. At least now you know how likely you are to need more surgery or less. And less is still the name of the game. You can only get to less when you've done better and then can start to back off. But now backing off is more about being precise, so being right. When do you add Herceptin? When do you add HER2-targeted therapies? When there's HER2 to target, not when there isn't. That has made all the difference. And now we're going to have the same kind of revolution, I think, in immunotherapies. How will they work? When do you use them? This is precision. And that's what we're supposed to figure out every time we see a patient. It's not that we didn't always have the same job. It's that the tools have come to make us better at our job and make our patients do better.
I would just add to that, Larry, that what we're all really talking about is also having more options. I don't think any of us would presume that because we have a test that says you're more likely not to progress, that we would say you're absolutely not going to be able to do a surgery. I think in our game, de-escalation is now the new buzzword, as Judy was alluding to, but I also think that providing more options for patients, I think, is usually a good thing.
Yeah, I think we'd all agree with that. This is the second time we mentioned immunotherapy, and I think we should bring that up. Who's here who wants to talk about that, folks? We've got at least two experts in the room. Somebody stand up. Whoever stands up first gets to talk. Well, actually, Hope is here also, 3. Okay, please. Could we have a mic over here, please? Where's our mics? Hello, mic people? No? Here you go. Here you go. I'll give you my. Oh wait, you got okay. Say who you are first.
So I am Leisha Emmons, and I also was at Hopkins for 20 years, and I recently relocated to the University of Pittsburgh as of September 1st as well. And I have been dedicated to developing immunotherapies for breast cancer for 20 years. It's really a delight that we've just had the first big news of a large global randomized phase 3 trial that showed a benefit for immunotherapy in selected patients with metastatic triple-negative breast cancer. And it looks like the story is that you can use PD-L1 as a biomarker to select patients who can benefit from this. There's a very modest improvement in progression-free survival, particularly in the PD-L1 positive patient population. This is first-line therapy, so this is the very first therapy that people get for their metastatic disease. But more impressive is that there's a very clear improvement in overall survival of about 10 months. And the study compared patients who received a type of chemotherapy that's routine, for treating metastatic triple-negative breast cancer called nab-paclitaxel or Abraxane with a placebo drug, or the combination of nab-paclitaxel or Abraxane with an immunotherapy drug called atezolizumab. So the people that got the chemotherapy with the placebo control had overall survival that was consistent with the standard, and the people that got the immunotherapy added to it had a 10-month survival benefit relative to that. So it's actually very exciting now that we can use that biomarker in a very precise way, potentially to select these patients. Whom I don't know if you'd like to say anything.
Yeah, you mentioned a couple things. I just want to do a quick definition, then I'm going to ask Hope to explain something, which is triple negative. We have a standard classification. We're talking about very sophisticated, actually look at a sophisticated group of molecules here. But for many years, we've looked at the tumor cells. Do they have receptors for estrogen, receptors for progesterone, and a molecule called HER2 that is related to growth, signaling, tells the cell to divide. And we have specific therapies for those, for estrogen receptor, a variety of hormone therapies, for HER2, now a variety of HER2 blocking agents. But there's some patients whose tumors don't have estrogen receptor, progesterone receptor, or HER2, so we call those triple negative. And it's a grab bag of different types of breast cancer, but that's sort of a classification. And there's been long suspicion on the basis of your work and your colleagues' work that those tumors perhaps are the most potentially sensitive to therapies that relate to the immune system. Is that correct? Yeah. And so so those are the patients that actually were studied in this regard. And you also mentioned something called PD-L1. I'm going to ask Hope to do it just to get so you can have to do it. Well, what is this PD-L1? What does that mean? And you were involved, obviously, in the study as well.
So the story of PD-L1 is still very complicated, but and I'm Hope Rugo from the University of California, San Francisco, where I'm a breast medical oncologist. But we've been looking for markers all the time. I mean, in hormone receptor positive disease, we have some really great targeted agents now, but we've had a lot of trouble, until quite recently, finding anything on the cancer itself that tells us whose cancer will do better with a treatment versus which won't. So selecting it like we select with the estrogen receptor. PD-L1 is a marker of immune activation on the cancer cell. Maybe it would make it a little more sensitive to the host immune system. But the tumor has this way of putting an invisibility cloak over itself to hide from the immune system. And the idea behind these drugs, like atezolizumab, is that it can make the tumor visible to the immune system. So in this study, we found that patients who tumors had, or the cells around the tumors had PD-L1 were more sensitive to the treatment with the immune therapy with chemotherapy. But the patients who didn't have that on their cells around the tumor had some effect. It just wasn't a very big one. So one of our big challenges is to try and convert those cancers to be more sensitive, to have the cancer be seen by the immune system. One of the things we found out, which I think has been fascinating for all of us, is that as the cancer grows, so the cancer comes back, it's metastatic, and then it grows through treatments, it becomes more and more resistant to the immune treatment. In other words, the cancer finds ways even better over time to escape your immune attack on the cancer. So we have shifted our thinking in a way that I think we've been trying to do for a while to move everything earlier. That's a lot of what the panel was talking about. So immunotherapy has worked much better, apparently, if you treat the cancer right when it's diagnosed, early. And in that way, we could prevent the recurrence. It may be that that's when the immune system is going to be most active and most plastic, most maneuverable by the different treatments. We actually have funding from the BCRF through our Translational Research Consortium to look at combinations of immune therapy to try and enhance that effect. And in the neoadjuvant setting, if we can give the immune therapies there, maybe the cancers will have a chance to respond before all the resistance develops.
It's a great explanation. What she's referring to is actually, I just want to make a call out to Pfizer in this regard, is we, BCRF has made this relationship with Pfizer as a wonderful relationship where we can actually use their drugs, and they've actually funding trials that were selected in a competitive kind of fashion to actually move forward. And this collaboration between a nonprofit, publicly oriented organizations such as BCRF and a pharmaceutical company is really unique. It's moved on, Astellas, and we hope that others are going to be joining us in this collaborative relationship where we can get really exciting drugs and get the funding to be able to move things forward. And that's the general family of trials that Hope is alluding to. Ben, do you think there's any possibility that we'll be able to do blood tests someday and identify cancers before they actually form by their abnormal DNA, and maybe even start to use immunotherapy in that setting as a way of eradicating the cancers before they even form?
It's a very provocative question, and one that many of us in this field have addressed or thought about. It's challenging right now because as much as I'm a fan of liquid biopsies, as we call them, when we see mutations in the blood, we don't often know exactly where they're coming from. And some of these so-called driver genes that I was talking about earlier can actually occur in different types of cancers. Colorectal cancers, for example, and breast cancer sometimes have the same driver genes. And that presents the challenges. And as we've also learned more from this field, it turns out as we all get older, we're probably also getting mutations in our blood. And they probably don't mean anything for the vast majority of us, but we can detect them. And so that complicates the issue more. So I'm not convinced right now that a single blood test will be useful for a general screening. I could be wrong. In some ways, I hope I am wrong. But I think that's what we were really getting together for the past few days, thinking about how do we use that information as a secondary test, if you will, or an adjunct test with things like molecular imaging. Big data is a word or a couple of words that we're throwing around a lot, but if we have things even as kind of mundane as demographics of where you happen to live or your zip code, put all that together and let computers and artificial intelligence really try to learn from our past patients, maybe we'll move forward in that regard and be able to identify someone with the blood tests and other modalities in the future and say, hey, there's an opportunity to intervene. Assuming that we'll also figure out whether we should or not, that this could just be a benign thing or this is something that's going to be really aggressive.
Yeah, I got it. This is totally a comment that with very, very soft relevance to this. It's not the usual kind of thing we're discussing, but that I was at a dinner of supporters of BCRF the other night and sitting next to somebody who has really started a business in terms of providing things to homes, via the internet. The specifics really not important. What was really important was how much you can learn about each one of us if you have access to big data. And that already. When you go, as soon as you log on, to the internet search engine, you get these ads that are very specifically targeted to you. You know who you are and you know what you purchased before. And so that, if you bought a fishing rod, you're going to get phishing ads and so on. Actually, it happened to me. I'm sort of an amateur musician, and I had a very unusual instrument. I was looking for a case for it, and I couldn't find it. Somebody suggested that maybe, a case for a fishing rod would work. So I hunted for fishing rods. I didn't find one. But from that point forward, I'm constantly getting fish ads, all right, all sorts of, and it's some really interesting stuff. So much so that I'm actually thinking about taking up fishing, all right. So it's actually influencing what I do moving forward. There is a suspicion that I've heard from people there too, is that there may be hints about cancer etiology that we are not thinking about, all right? And forgive me for running on this because I think this is really sort of fascinating, is that the link between cigarette smoking and lung cancer took us centuries to figure out, all right? And big data would have figured that out almost instantly, all right, just by matching lung cancer and purchase of cigarettes, and finding that people who don't purchase cigarettes or cigarette paraphernalia, like lighters and whatever, with a very low incidence, and it would have found it very quickly. And that there may be things out there that we're doing that we're not even thinking are related to cancer incidence that might actually be related to cancer incidence, and that kind of data mining, which is advancing very rapidly in the commercial space so that they can sell us stuff and give us what we need or convince us we should become fishermen. It may be something in the future. I'm just really fascinated by that as a potential subject. Judy, there are people, though, that we already know that are extremely high risk, right? And how does all of this evolving science relate to them? Who are they, and how does the science relate to them?
There are a lot of different places we could go with this one. So I think one thing, maybe just a message for today, is that people who were interested in genetic testing in the past, who either had breast cancer, wanted to know did they have a BRCA1 or 2 mutation, and had testing before, like before 2010 or 2012, might have been tested for BRCA1 and 2, but now there are many more genes and there's even more complete testing of BRCA1 and 2, so people may need to think about being retested. Somewhere we expect that we'll be testing all of our DNA. There are already programs to do this, but we're still focused largely on cancer and on making cancer testing more available so that you know something about a mutation you might have that would put you at risk. We're still trying to figure out the reason that some people who have these mutations, an altered gene that they've been born with and all their lives developed normally, had kids, seem to be fine with one normal copy of one of these genes, but something happens and a tumor may begin to form when a cell loses the normal copy and the protection that it offers against cancer, and allows more and more of these mutations to accumulate. Ben was talking about that cancers make mistakes all the time, and it turns out that many of the genes that make us more susceptible are genes that are involved in making the cells replace their DNA perfectly every time and not make these mistakes. Lots of people in this room funded by BCRF have figured out how this happens, why this happens, and ways we can intervene. Once we understand some of these a little more, we've been able to think about ways to try to target treatments. And that's been very important. But even there, where we have funded lots of work, we still have some fundamental questions, like why people who have a BRCA1 mutation are more likely to get the triple negative tumors Larry was talking about, where they don't have estrogen receptor or progesterone receptor or HER2. But people who have BRCA2 mutations, which interact directly with BRCA1, get tumors that are mostly estrogen receptor positive. Understanding, though, that these tumors develop with these genetic mutations now has led people to think about specific treatments for these tumors that exploit this errors in the DNA repair pathways that these tumors are particularly driven by, that other tumors are not. So more clues, more what to do. The idea that we could spare our patients with mutations the constant screening, the mammograms, the MRIs, all of this all the time, and could use a blood test perhaps to screen would be great, assuming that it is as precise as Ben is suggesting that it has to be. Maybe we could even use this to help us figure out when to time surgery so we wouldn't have to do that so soon, just to prevent cancer, which is, after all, still part of the goal.
I mean, you're talking about the fact is that some people who have these high risk of getting cancer do prophylactic surgery. Is that what you're addressing?
Yes, they do, or having their ovaries removed, at least, since there's a place where we really have hardly any early detection, maybe none, that works.
So the idea is that even in these very high-risk individuals, it's possible. What I'm thinking about is, I mean, the connection here is that, if indeed the reason that people may have a very high risk is they've got DNA repair defects, so that they're developing mutations, that means that for the most part they're developing mutations. If the mutations can be detected, and then with extraordinary advances in molecular imaging, you say, and you were talking before about the fact that people can have mutations and not have cancer, people can have mutations that are the same from different kinds of cancer and different organs. If sophisticated screening, very specialized screening tests could then pick out where it's coming from, or find out it's not coming from anywhere and it's probably benign, we don't have to do anything, then putting together this molecular imaging, putting together liquid biopsies, identifying the individuals at highest risk, then could lead to no therapy or specific therapy or something of that nature. Is that kind of the issue we're dancing around?
Yeah, and I think that perfectly encapsulates it, Larry. I think where I see where blood tests could also be useful is when we're trying to distinguish between an indolent versus a truly aggressive type of cancer, because the nature of these liquid biopsies, as we call them, are quantitative, not just qualitative. We not only can see the DNA mistakes in the blood, but we can measure how much, and those are directly correlated with how much cancer cells you have. you could imagine a scenario where, we use the term active surveillance because watchful waiting was causing too much stress. But with active surveillance, you can measure serially, maybe every week, every month, and see whether or not that level of cancer DNA in the blood stays the same or starts to rise. And then you have a window of opportunity there to make an intervention if that occurs. So I think that this all ties together. It's one of the things that our group and many others are working on, but it does take a collaborative effort. And again, putting all these great minds together and coming up with this platform, I think is really the way forward.
I would just mention also for those of you who are, assembled here is that we often put very clinically oriented people up here in front of you because a lot of the questions that are going to come to us in a few minutes are going to be clinical. But BCRF has a tremendous investment in very basic science as well, and we've got some of the very best basic scientists in the world in this room and in the BCRF family studying very fundamental issues about how cells behave, how DNA works, and some of the very same things we're talking about. Because it's connecting that fundamental understanding with the bigger issues that we're discussing is really where the advances come. And everything we're talking about here is based on very fundamental science. I mean, fundamental DNA science and RNA science and molecular biology. And I think that this is something that is very important for the supporters of BCRF to understand, is that it's not zeroing in on the answer is we're going to put all our eggs in that basket. We are spreading a very wide net and looking for answers wherever they possibly could come from. And honestly, I'm looking around the room to my colleagues on the left and right, and each and every one of them I could ask to speak now, and some of them are just itching to do so. But on the other hand, we have to keep this contained and finish before dinner. That's our job. Oh, we have lunch. We have to finish before lunch. So that's really our job. There are cards out there. Please pass them all up because we'd like to see what some of your questions are. You already got a big pile. Could we bring the cards up already and give them to Judy that you have? You can keep writing cards as you go on, and we still have some time. If we could bring the cards up. You're walking away from me where you should be walking toward me. You're actually walking out the door. If you could bring the cards up, maybe walk faster as you bring the cards. You don't have to get all the cards. Just whatever you have in your hand, bring them here now, please. I don't want to talk about that. Okay, so just bring the cards up right here, and Judy's going to sort through them, and we'll have a few questions. Okay. Okay, good. All right, good. Judy, pick a good question. It's enough cards, folks. We have lunch to get to at some point or other.
I think we either confused you a lot or engaged you a lot based on the number of cards here.
Well, so here's one for Dr. Sparano. What excites you most about the future of breast cancer research given the recent exciting results of TAILOR-X? So maybe you could explain a little TAILOR-X.
Yeah, maybe go into more detail. You already mentioned TAILOR-X. Describe it again in more detail so people really understand what we're talking about.
Sure. So TAILOR-X was a National Cancer Institute federally funded large clinical trial, involved about 10,000 women who had the most common subtype of breast cancer, that is tumors that express the estrogen receptor and do not express HER2. And were associated with negative axillary lymph nodes. So this accounts for about 1/2 of all breast cancers in the U.S., about 125,000 women each year, about 8 to 9% of all cancers in the U.S. And where we were about 15 to 20 years ago is that we had shown that after removal of the primary tumor and local therapy, we knew that despite the fact that the disease presented at a very early stage, that up to 30% of women could ultimately have a recurrence of their disease in other parts of the body, which was incurable. We knew that we can reduce that risk by giving endocrine therapy for a period of 5 years. And in the mid-'80s to late '90s and beyond, we showed that in this group of women, we can, by using chemotherapy after surgery, we could also reduce their risk of recurrence, presumably because we were killing microscopic cancer cells that were lurking in the body that we could not otherwise detect. And clinical trials from around the world essentially donated their data to a data bank and a group of statisticians who analyzed that data, the Early Breast Cancer Trialist Collaborative Group. And when they analyzed that data, they found what they couldn't really find from individual studies, that even women who are at the lowest risk of recurrence benefited by giving chemotherapy. And the tipping point was in around 2000 when there was an expert panel convened by the NIH, the NCI, and this expert panel essentially recommended that every woman who was diagnosed with an early stage breast cancer, even those women who had this stage 1 disease that was ER positive, HER2 negative, be at least considered, either recommended or considered to have adjuvant chemotherapy. So that's where we were. And as a result of that, or at least part of the result of that, breast cancer mortality rates have plummeted. It's in part due to screening, but also due to the more widespread use of therapy. So that's the position where we were in, and around 2005, a new gene expression test became available that many of us found intriguing because not only could it provide prognostic information above and beyond that prognostic information that could be provided by the usual features, but it also, in one very small study involving about 600 women, showed that you can identify a subgroup of about 25% of those women who were getting all of the benefit from chemotherapy. And as clinicians, as this test became available, people were finding that there actually weren't that many people, as we initially thought, who had scores that were in the high range, directing us to chemotherapy.
Scores, what are you talking about? What's a score?
So this is called a recurrence score. It's computed from the expression of the genes from 0 to 100.
Expression is the DNA making RNA? Is that what you mean by expression?
RNA of the genes in the tumor. And the breakthrough was not just the ability to correlate the expression of these genes with these outcomes, but actually there was a technological advancement that would allow us to be able to extract the RNA from tumors that were placed in paraffin. In other words, they were routinely obtained and processed. So that was really the second technological breakthrough that allowed one to order this test like you would order any other test and not need to collect the tumor in any specific way. So as this test became available, clinicians became more comfortable sparing chemotherapy over the years, but also found that there was a large group in the mid-range where we weren't quite sure whether chemotherapy was of benefit. And that's what the TAILOR-X trial was designed to address. So it took the information that we knew about the test and directed women who had a low score to endocrine therapy, hormone therapy alone, because we knew from prior studies that those women did really well. And for those who had a high score, we directed them to chemotherapy. But for the 70% of women who had a score that was in the mid-range, we randomized them to chemotherapy, endocrine therapy, versus endocrine therapy alone. And there were 10,000 women who volunteered for the study. And at the end of the day, after 15 years after this journey began, we unequivocally demonstrated that chemotherapy was of no benefit in that 70% of women. Now,
and they did well, even
yes,
without the chemotherapy.
Yes,
that's the
very
other
well.
point. Right.
Yeah.
So we've expanded the range of patients that can do well and don't need chemotherapy to achieve that doing well by this test. Is that another way of saying it?
Absolutely. We can direct the chemotherapy to those women who really benefited.
Well, the question was, as Judy says, where do we go next? What are your other ideas? Where are you going to go next with this, Joe?
Well, I think the next frontier is one of the next frontiers for me. What I'm interested in is a late relapse question because, as I said, this type of breast cancer is the most common subtype, and it turns out half of all the recurrences with this breast cancer subtype occur after 5 years. And chemotherapy prevents the early recurrences. It doesn't really prevent the recurrences beyond 5 years. And so I think we need to, and all of our clinicians who see patients can see patients who've relapsed 10, 15, 20, 30 years. And I think we need to develop better clinical tests to identify who those women are who are at higher risk for later recurrence. There are some of those tests available, algorithms. They're based on the things that predict early recurrence, lymph node positive disease, larger tumor size, higher grade. But also blood-based tests that can perhaps identify who is at risk for that late relapse. And that's what the BCRF funded a project that I've been involved with for about 5 years to take that population of women who are 5 years or more after a diagnosis, who had already participated in a clinical trial, and we were following them anyway. And we asked them to donate additional blood specimens. And we've now created a bank that includes specimens from over 2,000 women, over 10,000 specimens. And we took a look at the first look we took at these specimens was to do a specific test to look for tumor cells circulating in the blood. This is a test that's commercially available and approved for metastatic breast cancer. And we found that about 5% of these women had circulating tumor cells in their blood, despite the fact that clinically there was no evidence of disease. And we followed them. And what we found was that these women had about a 13-fold higher risk of recurrence. At the end of 2 years, there was about a 30% risk of having a recurrence versus less than 2% that had a negative test. This has been validated in one other study. So the next question is, well, what can we do about that? And right now we're in the process of planning with the National Cancer Institute and the cooperative groups a trial that we call LATER and LATER RX. The LATER trial will be a trial where we do this blood test, identify that 5% of women, screen them, and then move them into what we call LATER RX. And we will then obviously need to evaluate those women, do imaging tests to make sure there's no evidence of distant spread. And for those whose imaging tests are negative and we know are at high risk for relapse, test an intervention to see if we can prevent recurrence from happening. And so this is one of the, I think the next frontier.
Are you going to be incorporating cell-free DNA into that trial?
Yes, in fact, thanks to BCRF funding, we just completed a pilot study where we took some of the samples that were collected to look if there's an adequate amount of cell-free DNA to do that testing, and we're going to go back on those samples that have already been collected to do some of those tests.
Fascinating. Judy, another question?
We've got a lot of great questions, so let's do this one. Will be a little more laboratory-based, but everybody knows about CRISPR. People want to know, what is CRISPR, and how can CRISPR technologies help in breast cancer?
So CRISPR is it's an acronym really, and it's also called CRISPR-Cas or CRISPR-Cas9. This is a new technology that was developed by several different groups a number of years ago. What this allows us to do is actually in the lab, we can take a human cell or a mouse cell, and now we can precisely change just a single DNA molecule. And so what our lab has been doing even before CRISPR, but now using this new technology, is to change a normal cell and introduce one of these driver mutations and subsequent additional mutations so that we can really understand the biology of how you go from normal to cancer to metastasis. And even though CRISPR wasn't kind of created for that technology, a lot of us in the cancer business are using it for that purpose. The question that arose, though, is that do we ever foresee a future where this type of technology, CRISPR or otherwise, could be used for prevention? I think that's a really good and difficult question to answer right now. I could see how someone might think, hey, if I have a BRCA mutation that I know is a true pathogenic mutation, couldn't I take out some of my eggs and do CRISPR and fix that mutation? Or, even at the embryo stage, could we go in and actually fix that with CRISPR technology? There are some scientists around the world, not in the United States, that are starting to explore that very question. I think here we've been a lot more cautious, and I think rightfully so. This is something like the eugenics movement. We're not really sure whether this, even if we can do it, should we do it? What are the implications of that? Are we going to be creating superhumans in the future? And these are all really powerful questions that require lots of thought, input from our bioethics people, et cetera. So for right now, I would tell you this is still more science fiction than fact, but I do think that there will come a day where this type of technology will probably be mature enough to technically do it. And again, I think the next question that needs to be answered, and we're having those discussions even today, is whether we should do that.
Yeah, I'm looking forward to CRISPR for growing hair. All right.
Me too.
So that's anybody's interested in a BCRF grant to use CRISPR technology to turn off the gene for baldness, please see me after this session.
Well, you never know where this will go. So, is Walt here today? There's a question about aspirin. So there are many other people in the audience who can answer aspirin. There was just a whole issue of JAMA about aspirin. Is it still going to?
Who wants to get that? Stand up.
Can't see.
Oh, there-
No, you got to stand
so-
because otherwise I
I
can't.
know-
You know, the lights are such we can't see you.
Your
All
group
right.
has worked on aspirin. There are others in the audience who also want to speak to aspirin. What's the deal with aspirin? Should we all be taking it? Shouldn't we be taking it? Women, men?
These new studies were...
Who are you?
Yes, Walter Willett. I'm a physician and epidemiologist, happy to be supported by the Breast Cancer Research Foundation at Harvard. And this is a complicated issue because aspirin seems like a little benign thing you buy over the counter, but it's actually very potent, and it has serious side effects, hemorrhagic stroke, bleeding in the gastrointestinal tract that can be fatal, but it also is very clear that it does reduce risk of cardiovascular disease. It's also very clear that it reduces risk of colorectal cancer. Probably doesn't have much benefit for reducing breast cancer risk. That's been looked at pretty clearly, but maybe it will help survival. So there's lots of risks and benefits to balance out here. And these new studies that came out show that in a generally healthy population, the risks and benefits pretty much canceled each other. So I think this is an area where it is a potent drug, even though we sort of almost belittle aspirin. And what will really be necessary is to more stratify the population by identifying people where the benefit is more likely to be greater than the risk. And that's like almost any medication, but here it's something that almost seems benign over the counter, but it really is a potent drug. So identifying people who are at risk, say, of heart disease and might benefit, and also at low risk of hemorrhagic stroke or some of the other side effects, that would be the kind of person who might benefit. So if you're contemplating taking an aspirin for prevention, it's really a good idea to discuss that seriously with your physician.
So I always tell my patients that I'm trying to keep them alive after breast cancer so they can have heart disease. But I think that the challenge here is to know about aspirin, and there is an adjuvant study led by Wendy Chen at our institution, supported by the Department of Defense, looking to see whether adding an aspirin to standard breast cancer treatment actually improves outcomes. So we're looking, hopefully, for the results of that study too, that at least should help with more than one endpoint, but may have side effects to manage also. Larry, maybe you could answer this question. So several people really ask the question, when you hear about new breast cancer treatments, it's very tempting to look at what you've had yourself and ask, how can I get some of that, or should I add something? Should I had my Herceptin, my doctor's so happy that I'm doing well, but should I be tested for things to tell me if I need to take immunotherapy? I had triple negative breast cancer. Should I be doing something? How far out am I? Do I still need to think about risk? We're hearing about late recurrence. How do you manage that time in the middle when you've had the treatment everybody said you're supposed to have, and now something new comes along and you wonder, should I add that in?
Well, if you actually look back, I mean, this two-part question is I got a therapy that I really needed. Obviously, you can't do anything about that now going back, but for the most part, when this issue has arisen in my own patient population, the decisions we made back then were very rational decisions based on the data we had then and a cost-benefit analysis, in that situation. And I haven't seen too many cases where I've had to go to somebody and say, you were harmed by the therapy. Chemotherapy for that intermediate group that Joe has found out is if the properly chosen chemotherapy, long-term side effects are not a big problem, and so you might not have been helped, but you weren't harmed, either. But the second part is what am I doing now am I doing all the right things now? Should I be doing something different now on the basis of this evolving information? And this is a really very, very interesting question because, again, too, I've seen the whole evolution of medicine where things changed very slowly and now things are changing extremely quickly, and sometimes week by week. And new information becomes available, and we have to sort of react to it. And the question of how to educate the general public, for those of you who have really good doctors who stay up to date, it's pretty easy. You talk to your healthcare provider, and they get the information. Part of the complexity is that not every doctor can be up to date on everything. And so like in Warsaw and Kettering, we've got a large group of people, 35, that just do breast medical oncology, and they're up to date on breast medical oncology, but they don't know necessarily what's happening in terms of what happened last week in colon cancer or in leukemia or lymphoma. And so even in a highly specialized situation like that, you're not going to have those sorts of information. And for a lot of people who don't have access to that kind of care, even in the United States, where you don't see your doctor very frequently, or your doctor is a general doctor who's not a specialist, it's a big problem. And when you get to the rest of the world, where access to any medicine at all, Eduardo Cazap from Argentina and I were talking about this yesterday. Just getting basic information can be a challenge. So I think this is really one of the really big topics that we're going to have to wrestle with, and I'm hoping that BCRF is going to get involved in education. Ken Offit, who I think is somewhere over there, I don't know, maybe I was wrong, but is in this situation, has been working with people who are interested in using apps, things on smartphones, to educate people on very difficult topics like genetic testing for breast cancer susceptibility. One of the things that's really impressed me traveling around the world is you can go in places where they don't have shoes, but they have iPhones. Is the penetration of electronic media for dissemination of information is really quite extraordinary in the world. I mean, literally, I was in a desert, this year where there were very tremendous deprivation of many things, but there were whole lots of iPhones around, basically smartphones around for people to communicate with, and it's really remarkable. So dissemination of information at a highly sophisticated level, I think, is going to be something that we're going to have to get into. It's part of the whole big data revolution in this regard. But specific information, not searching through many, many pages and trying to find the information from you, where you basically ask the question, I had this and this, and I had that and that. Is there anything new for me? And you can get the specific information for you, either in terms of things you can do or who you can contact to get specific information for you. When you think about it, we're doing this all the time in non-medical areas, where we were talking before about how people are trying to sell me fishing rods, right? In that kind of thing. They already know that they think I'm interested in fishing, in that regard. So, but you can imagine where, you could be signed up and, guess what? TaylorX results have come in and this is information for you, or the impassioned studies are related to immunotherapy, brand new, breaking, and you should talk to somebody about this. And if your healthcare provider doesn't have the information, this is how you can get that information. I think we're going to be seeing a lot of that coming off into the future, because there's no other way that we're going to be able to provide that kind of level of sophisticated information to every individual. And I'm hoping that BCRF can get into that as part of our movement into those new technologies. It's going to be part of something that BCRF is doing called a mathematics initiative that started with Taub Family Foundation and with and now Simon's Foundation, and we hope that others are going to be joining us in this regard, where we're going to bring together world-class mathematicians to bring mathematical skills into the process. These very same people are extraordinarily skilled in computer science, data technologies, image analysis, and analyzing complex molecular data. All involves the same math fundamentally. It's the same fundamental mathematics. And as we get more sophisticated in the mathematical approaches to these problems, I think we'll also get simultaneously more sophisticated in dissemination of information. So that's kind of where we're thinking.
Do you think, Hedwig, do you want to speak to that at all? You've made education a real part of your mission, and here you work in the most complex technologies and education at the same time.
Yes, it is one of, just like Larry said, Judy, one of the biggest problem is, and specifically with technology, we have, so the most sophisticated technology physicians use, or in our case, radiologists, a higher education you need. So it is a huge problem. We are trying to educate, and you are absolutely right. I think actually next week, a National Academy of Science is having yet another workshop, and the workshop is how to develop technology that will educate and help education. This one is for imaging only. and disseminate. But there's no question that when you work in a hospital like Memorial, when we have 22 radiologists that do nothing but primary breast cancer imaging. So they advance, and they have to be good. It's like cooking chicken soup every day. You are perfect. If you do it once a year, you have to read your recipe.
Her chicken soup is amazing.
So it's all how much you do and what we do. So one way it's going to, machine learning will help tremendously. Probably, I don't know if you heard, there was a paper everybody quoted that pigeons can read mammography as well as radiologists. Thank God. But machine learning, we call it machine vision because it's more than learning. The augmented artificial intelligence in our field is going to hugely help, and it's going to change the role of radiologists from just reading the films to really be consultant and be helpful to patients as well as our colleagues. But tomorrow is all about technology, just like Larry said, so we are all investing in that.
Thank you. So why don't we ask Dr. Offit if he would speak for a minute about this project or the idea of trying to bring information to people or get them involved in projects using smartphones. Ken?
Well, it really takes us with two critical questions. One is the educating of all of you, and then the other is the educating of your doctors. Both of these are challenges. So what we've set out to do as part of a demonstration project, and we is Judy, Nadine Tung at the Beth Israel, Beth Carlin at Cedars-Sinai, and Susan Domchak at Penn, is take a simple, what we think is a genetically simple test of a complicated challenge, which is genetically testing everyone. And what we're trying to do is take a simple genetic test in a high-risk group, those are individuals of Eastern European Ashkenazi background, and give them access on a smartphone to a free test, but also do this in a medical model to bring in their doctors as well. And Judy and Susan and I were talking about this at the seminar yesterday, that so far what we're finding is that folks are able to interact very well with their smartphones and get the information and give the consent, but we're not getting the physicians who they would like to get the results from to interact in the same way. And this is a challenge, I think, for all of us in genetics. We all would like to screen everybody, but we'd like to do better than commercial companies and just have you do this in the privacy of your back room. We'd like your doctors to be involved as well. So it's the technology, but it's also going to be, as Hedy is saying, the communication and education of physicians. And as we're talking about the next phase of the study, we're going to have to get the smartphones in the hands of the physicians as well as the patients.
Hand the mic to no, don't hold on to it. Stand up for a second, Mark. Mark Hurlbert has been the chief mission officer of BCRF. What is it, about 3 years? And is now he's now made enormous contributions to the breast cancer struggle. Now he's going to be moving on to making major contributions to the melanoma struggle. There's an app that you're interested in, right? You want to just announce what it is, because I think people should know about it.
Yeah, so with Dr. Neil Iyengar from Memorial Sloan Kettering here and several BCRF investigators, we made a new app that just launched last week called MBC Connect. It's for metastatic breast cancer patients. For anyone that's living with metastatic disease, we want you to join us. It's a registry where we will follow real time if you have a new progression of your disease and you're switched to a new treatment regimen. We want to know about that and what your quality of life is. So it's a new registry called MBC Connect. It's on Apple and iPhone and as well as Android devices. And we're trying to enroll women all over the U.S. And then early next year, we're going to be in 4 European countries. Thanks.
If I could also just add, I forgot to give our web address as well for our study, which is the BFOR study. And if any of you would like and have a background, Ashkenazi background, or friends, this is a free test. It's a study. BCRF is supporting it, and it's open at least for the next 6 months. B4 study.
Right. Anybody else here have an app that they want to talk about? Judy, go ahead.
Okay. So this is an important question about proton radiation. I think a lot of people have heard about proton radiation. Does it have a role in breast cancer? What's the best way to do this? So we have some radiation oncologists in our Army as well.
Yeah, it's a common question. Who do we have?
I know Lori
Sylvia, you here?
Pierce is here. Sylvia, is anybody?
Huh? Please stand up. Hi. Yeah, stand up. They can't see you unless you stand. Let's get a mic over here.
Bruce Hafty here.
Oh, Bruce.
Oh,
Okay.
that's great.
Yes.
Thank you.
All right.
So the question was protons for...
Proton radiation.
Right. So
Is it
I think
safer, is it better?
the indications are still controversial. What we're doing at our institution, we have a proton unit, is taking
So
participating
Bruce, can you back
in
up 1 second, just explain the difference?
Yeah, what's a
or What is
proton?
proton and
Yeah,
why
proton
is it
is
not
a
regular?
form of radiation. It's really just radiation, but it uses protons as opposed to photons, which is a heavier particle. And the potential advantage is that it has some, the distribution and how it deposits the radiation may have some potential advantages in terms of protecting the heart and lung when you're treating comprehensive radiation to not only the breast or the chest wall, but to the internal mammary nodes and the supraclavicular nodes. But we don't know that it has an advantage. So right now, there is an ongoing national trial called RADComp, which we participate in, that randomizes patients to protons or photons. Only patients who are really getting radiation not only to the breast, but to the lymph nodes, the internal mammary lymph nodes and the supraclavicular lymph nodes. The intent of that trial is to determine whether the potential decreased dose to the heart and lung, particularly to the heart, may have a minor benefit in terms of long-term cardiac toxicity. So that's the actual dose to the lymph nodes and to the breast and to the chest wall is actually the same with both, and potentially there may be an advantage to the heart and lung doses, and so we'll wait and see. But right now, with the exception of some unusual cases and some cases of reirradiation, I'd say the protons for breast is still in the investigational stage.
Yeah, it just the question that comes up a lot, and I'm sure it's out there, is I got breast radiotherapy. It wasn't with protons. You know, should I feel bad that I was undertreated or mistreated? What's your answer? There are people here who have breast
Right.
conservation and radiotherapy.
So currently, with the techniques that we have, you know, careful techniques with photons, the doses to the heart and lung are very, very low. There's no clear advantage to protons over photons, and I think we'll only know by this randomized trial whether there's a potential advantage to cardiac toxicity. So photons, which have been around for the last 50 years or more, perfectly acceptable for the vast majority of patients, and I would say that those patients who want protons or think about them should consider the trial. There are some unusual situations. For example, I have a patient on right now with very unusual anatomy, and the protons had a clearly distinct advantage. She had what's called pectus excavatum, which is the shape of her chest was different, and her heart was really up against the chest wall. And in her case, protons had a clear advantage, but this is very rare. So I would say vast majority of patients do fine with both techniques, and if there's a potential advantage, we'll know by the ongoing RADComp trial.
Thank you.
Thank you. So one topic that hasn't come up at all this morning are ways to make hormonal therapies stronger. So we've had tamoxifen, we've had aromatase inhibitors, now we have the CDK4/6 inhibitors. When do we take them, and what are they going to do? Larry?
Goodness gracious, who wants to do this one? Huh? I'll start off in general, because I think that we have people that are actually working on the science, and I'll just do this as a sort of a general thing. Is that hormone therapies are very effective for estrogen-dependent breast cancers, and we can tell. Again, we're talking about markers, you know, like PD-L1 as something the cancer cell may have that may make it more amenable to immune approaches. We already know that if the tumor has estrogen receptor in it and has estrogen receptor on its surface, that it's going to be more amenable to hormonal therapies. And hormonal therapies are very effective, but one of the key things that we haven't talked about at all, but it's very important, that we're focusing a lot on modern cancer therapy is drug resistance. The ability of cells to outsmart outsmart our doctors, outsmart our drugs by developing mechanisms of resistance. George Sledger, somewhere in the audience, had a wonderful phrase on this about, one dumb cancer cell being smarter than 10 oncologists or something of that nature, if I have it right. Because cells are just, the reason that we survive as a species, the reason why we've got mammals running around this earth is because, we can deal with poisons. And that our body has various defense mechanisms. Our cells have defense mechanisms for chemicals that may get into them that may harm them. We can pump the poisons out. We have what's called redundancy. If the poison hits one pathway, there's another pathway that can come on. And all those things can hurt us in terms of cancer therapy because basically we're trying to damage the cancer cell. To the cancer cell, our therapies are poisons, and they're trying to overcome them, and they have mechanism of resistance. And we know what some of those mechanisms are, something called mTOR, something called CDK4/6, and others that are rising. Maybe even something called PIK3CA, PI3 kinase. And that's, again, an evolving area. So one of the really hot topics now is the use of drugs that can be combined with hormonal therapies to overcome those mechanisms of resistance. And the CDK4/6 inhibitor family of drugs is one of them, and it's really had real clinical utility as well as drugs that that attack mTOR and other things. So it's a really rapidly evolving area. I would just say I don't want to go into great detail about who should and who shouldn't. It depends upon the individual situation. And I think one of the really interesting topics to me is, are there tests that we can do of the tumor or of the peripheral blood that can tell us who would benefit from the addition of one of these medicines? Or maybe start with a hormone therapy and at a certain point add in a CDK4/6 inhibitor if you see the resistance beginning to emerge. So I just wanted to start this off. Who else wants to make a comment?
I was just going to add to that for right now we have 3 of these drugs, CDK4/6 inhibitors, CDK4 and 6, are molecules in all of our cells, but particularly in cancer cells, they tend to be kind of turned on a lot. And so for whatever reason, some of the reasons that they seem to be much more effective in estrogen receptor positive disease, but the 3 drugs that are approved are really only for metastatic patients right now. And there are studies afoot ongoing, looking to see whether if we add this to early stage breast cancer patients, whether that'll afford benefit or not. And so for right now, I think outside of a clinical trial, we wouldn't recommend this to patients with early stage breast cancer until we have the results of those trials, or would encourage patients to go on those trials.
So we've talked a lot today about biomarkers, tests that can predict benefit from therapy or prognosis, but also the response to a drug is a biomarker. We call it a pharmacodynamic biomarker, and that's I think a tool that we haven't utilized to the extent that we can. And the place to use that would be the pre-surgical space for patients who have an endocrine sensitive tumor, where we can add a targeted agent, a new agent, to see whether it can make the endocrine therapy more effective. Is it hitting a certain target, a certain pathway? And I think now that in TAILORx we've demonstrated that probably only 15% of patients benefit from chemotherapy when given after surgery. The same would probably be true before surgery. And so I think we have an opportunity here to use this pre-surgical space to better interrogate the activity of some new agents and use the response to treatment as a biomarker to indicate, to make decisions, go, no-go decisions. Dr. Esserman and others are using this with chemotherapy, this model, but I think it has great potential for endocrine therapy as well.
Fascinating. Judy?
So, Dr. Weinberg, did you want to say something?
Tell them who you are.
Bob Weinberg, MIT, Cambridge, Massachusetts, the other school in Cambridge.
Wait. It's also the other city, let's be clear.
It's a living.
And no comments about the World Series, please. I just don't want to hear about it.
Why not?
Why not?
Go ahead.
The CDK4/6 inhibitors is a beautiful example of how basic preclinical research, undirected, yielded enormous benefits in breast cancer patients. It started with studying the cell cycle of single-cell yeast and determining how they were able to grow and divide and grow and divide. Later, this was extended to mouse models of breast cancer, and once again, one found important actors in how breast cancers are able to proliferate in the body of a mouse. And only most recently, and again, it was totally undirected towards clinical treatment. Only most recently has one begun to exploit this information, which was done just out of curiosity, i.e. curiosity-driven preclinical research. Only recently has this accrued to the benefit of breast cancer patients and their treatment.
Bob's making a really important point, again, to us, this is about educating about cancer, but it's also educating about BCRF. I've heard this a lot from the lay public. You know, we have all these basic scientists who are just following their imagination. Can't we direct them and tell them, you know, to study this in particular study of relevance? And most of the discoveries that have happened in the basic science laboratories over the centuries, all right, occurred because of curiosity, not because of, you know, directed, applied, you know, problem solving. So it's extremely important to have people that are just basically studying interesting things. They're just interesting parts of biology. But it's also extremely important to put them in an environment where they could hear clinical questions and they know clinicians and they could ask questions and they have some sense of disease, so a light bulb can go off and say, hey, you know, maybe this discovery that I made that's very, very fundamental, Bob has made several of these critical ones, could be applicable and could relate to human disease. And that's really one of the at the very, very beginning of BCRF, you know, the first hour of thinking about BCRF, the notion is we want to have basic scientists and not tell them what to do. We want them just to follow their imagination, but we want them in the room with others that are taking care of patients and are interested in survivorship and interested in all aspects of cancer, so that we can have, you know, interactions. And one of the great thrills of my life happened yesterday, basically, because we had a scientific seminar, you know, that was, you know, in the whole afternoon yesterday. And just to see the ease of interactions of people of different disciplines, you know, very basic people from very applied people, from, you know, doctors who take care of patients and people interested in all aspects of the problem, just interacting together in a very relaxed way, asking really challenging questions of each other, and you know, so many ideas were flying that we couldn't even keep track of them, and I had to say, please, you know, write them down or send us an email or a text so that we can keep track of these ideas. And so that's really one of the wonderful things that BCRF is all about. It's been 25 years. We've made astonishing progress. We're going to make more progress, and I think part of it is because of that enormous interaction of these incredible scientists and doctors and investigators that we have around here, who you're all going to get a chance to applaud on the stage, you know, very, very shortly. So I just wanted to give a plug for the BCRF model because it's just something so personally exciting to me. So thank you. All right. Sadia, are we getting close to the last question? Okay, all right.
Okay. So, Laura, I'm going to ask you to handle this one. People ask very interesting questions. This is really the question about breast density, the yin and the yang. Is it good? Is it bad? What does it mean to get these letters from your radiologist saying, congratulations, you have dense breasts on your mammogram, and we're not sure your insurance is going to cover any extra tests, but we think you might want to have one. What should we do?
Well, I think that's right. I mean, we know that breast density is associated with increased risk, but just because you have dense breast doesn't mean you're going to get breast cancer, and it's only if you have the most dense breast that you have the higher risk. I think this is about giving information out ahead of our understanding of how to manage it. You know, I think that this is, in general, we have an enormous amount of confusion about screening, about the guidelines, about what to do, and I think a lot of the work, you know, the reason why experts disagree is because the data is 30 and 40 years old, and I think it's high time for us to generate new information about how best to screen, how best to identify who's at risk for what kind of cancer. As Dr. Risak was saying, you know, most of these screening trials that told us about benefit were conducted when we thought breast cancer was one disease, and what you heard this morning was nothing could be further from the truth. There's lots of different cancers. People have lots, and Judy was just saying there's lots of different risks. Surely, one thing we can all agree on is that we have to do better. And one of the ways in which we do better is we do modern era trials. We start generating the data in more quickly, not something that will take 20 years. And along with my colleagues at the University of California, we've started this study called the Wisdom Study, to test annual screening versus personalized screening. And that includes information about your density. What we're trying to do is figure out how do you use this information to help. And we had this fabulous prevention think tank on Tuesday where we were trying to think about how can we use things like breast density as a marker of risk, like a cholesterol. Maybe the best thing to do is find out what's causing it, how to reduce it. There are people like Valerie Weaver who are doing basic science about that. Lots of people doing that. This is our opportunity. What I say is that everyone should sign up and participate in these screening studies where we can do better. And I'm really grateful that the Breast Cancer Research Foundation is helping us move the wisdom study across the country. And we can add on these density studies, and instead of arguing about what to do, let's generate the evidence. We need to have trials that all women can participate in, so we're all part of the process of generating this evidence. And I think I applaud the Breast Cancer Research Foundation for really helping us to do that. So I encourage everyone not to be fixed in your ideas. We can all agree that we can do better. Demand the iPhone 15 for breast screening. So let's everyone stand up, share their wisdom. If you get the opportunity to join in these trials and studies, do it. Because we don't know the answers, but we want to generate the information so that you can do better in 5 years. Your daughters, your friends, your sisters, your mother. So thank you all for all you do.
Yeah. Well, Laura, you got to work on getting more enthusiasm about stuff. Judy.
Somebody wanted to add something.
Okay.
Hi, Wendy Berg. I'm at University of Pittsburgh School of Medicine and actually have studied issues of dense breasts for a long time and tried to improve screening for such women. And I think one of the things that frustrates me is that, as in many areas in the world, we know a lot, we can do better right now. While we're working on doing even better, we should be implementing what we already know. One of the things that we do know is that tomosynthesis, their 3D mammograms, do improve compared to standard mammograms in women with dense breasts. So that should be demanded of every woman who has dense breasts. If you have extremely dense breasts that isn't good enough, tomosynthesis doesn't help. And that's where we do need to consider doing something better, or in addition to the tomosynthesis. We don't give up on the mammogram because it still finds cancers we don't see on ultrasound, for example. I've studied ultrasound a lot, and it is far from perfect, but it is helpful in finding invasive cancers that we don't see in extremely dense breasts. And meanwhile, there's a lot of work being done that Liz Morris talked about yesterday, and many studies are going on about abbreviated MRI to make it more available and cheaper. But in the meantime, identifying women at risk is something that we aren't doing very well in practice, even though we kind of know a lot about it. And I think this is one of the biggest challenges, and again, Liz and Hetty mentioned this yesterday, is how do we implement this? I'm getting really impatient with all this. I personally was diagnosed with breast cancer only because I put my own information into the Taracusic model and found out that I was 20% lifetime risk and got an MRI. And that is, I even talked to my doctor about all these things. He's like, well, why do you want to get an MRI? I was like, well, I just spent all this time educating you about dense breasts and all these risk models, and this is why I want to do this. So it is something we're doing very poorly in the clinic today. Women need to demand more. That's why we need to educate women directly as well as their providers. There is a website that I've worked on. It's not a plug. It's totally nonprofit, but densebreast-info.org that has information about the different tests that are available. It has information about what works, what doesn't. It has information about all the risk models, just so women and their doctors can learn more about it.
Thank you. Thank you. All right, thank you.
Jeff Weitzel at City of Hope. I just want to make a point that breast density, and again, all of our researchers know this, can be manipulated. So in fact, we published a study showing that we could use a hormonal intervention to reduce breast density in BRCA1 carriers. And so I think it's both a biomarker of risk, but also one that we can use to monitor our preventive therapy. So this is one of the effects of tamoxifen. We know that women who receive it, their breast density goes down. So I just want to make that point, and again, trying to motivate people in terms of using risk reduction medications like that.
Thank you.
This all is falling into that whole space of prevention strategies, screening and prevention really coming together, basic biology, what makes a breast dense, and and what can we do to interfere with that density, and does that density change risk? So just a quick comment because we're running out of time. Who
Yes,
are you?
I just wanted to follow up on the question around MRI. I think the physics has gotten very much improved than before. So the high rates of false positive MRI is much better. And I think the data suggests that we need to use MRI more often in high-risk women, and we need to continue to support development of fast MRI, abbreviated MRI. And so the science that's actually, and technology that's driving progress in breast cancer means that we should change the way we and what we recommend for women in terms of screening.
Hetty, do you agree with that?
Absolutely, and thank you for making the comment. It sounds a little different and not self-serving when it comes from medical oncologists, but MRI has come a long way, just like you said, and if you know what you're doing, the false positive rate is really not what it was 10 years ago, so thank you for that.
So I was just going to say, we had so many amazing questions. It was not possible to get to all of them at lunch. You'll sit with people who are investigators. They may not be at your topic, but they can probably help point out someone who might be able to help answer your question if we didn't answer it. We'll be there. And as you can hear, people have thoughts and ideas and knowledge about areas that are not just exactly where you might expect their bailiwick to be. So ask away.
Right, and we have, the investigators are sitting throughout the room, by the way, and that's done intentionally, so you could ask questions, and, we could also be interactive, really, as an audience. I'm getting hungry. So it's getting time. We're getting very close to actually going into the room. I just want to basically thank this extraordinary panel, my co-scientific director, Judy Carver here, and Ben Park, Joe Sparano, and Hetty Resac, and all my colleagues who spoke out for a wonderful discussion. All right. Again, thank all of you for coming. Thanks for being here. Thanks for supporting BCRF. Together, we're going to be the end of cancer.